iron deficiency anemia. Iron deficiency is not synonymous with iron deficiency anemia. In fact, anemia is only a manifestation, it's a part of manifestation of iron deficiency. Why is iron important? Iron is important as it functions as an electron transporter. Must be in the ferrous state for activity, as ferric ions cannot transport electrons or oxygen. It is a carrier of oxygen from lung to tissues, and it's cofactor of essential enzymatic reactions involved in neurotransmission, synthesis of steroid hormones, synthesis of bile salts, and detoxification processes in the liver. Most of the 3 to 4 grams of elemental iron in the body is in hemoglobin. Much of the remaining iron is stored in the form of ferritin or hemosiderin in the macrophages of the liver, spleen, and bone marrow, or is located in myoglobin in the muscle tissue. When the body requires iron, it is released from the macrophages into the plasma, where it attaches to transferrin, which is a major protein responsible for transporting iron in the body. Now, hepcidin is the master hormone which physiologically limits the iron entry into the plasma from 3 main sources. That is the dietary absorption in the duodenum, release of recycled iron from macrophages, and release of stored iron from hepatocytes. When the body has a large amount of iron, more hepcidin is produced by the liver, which limits the further iron absorption and hence than the release from the stores. This is how iron homeostasis is maintained. At the same time, when iron is deficient, less or no hepcidin is produced, allowing more iron to enter plasma. So when there is an absolute iron deficiency, little or no hepcidin is produced, which allows more and more iron to be taken into the plasma. While in anemia of chronic disease, which is commonly seen in clinical practice, iron in the body is abundant. And since hepcidin is an acute phase reactant, there is high amounts of hepcidin produced, which limits the release of iron from the duodenum or from the macrophages. There is a hepcidin ferroportin axis. Basically, ferroportin is the cellular iron efflux channel, which is found in all tissues which export iron to the blood plasma. The hepcidin ferroportin axis is the one which controls the main flow of iron into the plasma from duodenum, from macrophages, and from hepatocytes. Iron requirements in males are to the order of about 8 to 10 milligram, while in females in the pre-menstrual age group, it's about 8 milligram, while in 14 to 18 years, it is 15 milligram, which is almost double. And in the, which is increases to about 18 milligram in the reproductive age groups. While in the postmenopausal, the requirement of iron is almost the same as that in males, to the order of about 8 to 10 milligram. Daily requirement of iron during pregnancy is around 27 milligrams, and lactation is about 10 milligrams. What are the various sources of iron in the diet? We can classify them into heme iron and non-heme iron. Heme iron is present in hemoglobin containing animal food like meat, liver, and spleen, while non-heme iron is obtained from cereals, vegetables, and beans. Milk is a poor source of iron, hence the breastfed babies need iron supplements. So the heme iron, as I mentioned earlier, these are animal foods, while non-heme iron comes for non-animal foods. Why is it important to discuss two different sources of iron? Because absorption of heme iron is a constant rate of about 20 to 30%, and this is little affected by the iron balance of the subject, and it is not affected by ingestion of other food items. The heme molecule is absorbed intact, and the iron is released in the mucosal cells. However, when you talk of non-heme iron, the absorption of non-heme iron varies greatly from 2% to 100% because it is strongly influenced by the iron status of the body, the solubility of the iron salts, integrity of the gut mucosa, and presence of absorption inhibitors or facilitators in the diet. Now, what are these absorption inhibitors or facilitators? The inhibitors of iron absorption in the diet include food with polyphenol compounds like cereals like sorghum, oats, then vegetables like spinach and spices, beverages like tea, coffee, cocoa, and wine. So when we have a lot of culture in India, people have a lot of tea after food. Now, tea, the tannin in tea prevents the absorption of iron, which has been present in the diet. Then foods which contain phytic acid like cereals, wheat, rice, maize, barley, or legumes like soya beans, black beans, and peas contain phytic acid. Now, the dietary phenols and phytic acid compounds bind with iron, decreasing the free iron in the gut and form complexes which are not absorbed. Milk again is an inhibitor of iron absorption because of its high calcium and casein contents. Now, what are the facilitators of iron absorption? Foods which contain ascorbic acid like citrus fruits, broccoli, and other dark green dark green vegetables, because ascorbic acid reduces the iron from ferric to the ferrous state, thus increasing its absorption. Then food fermentation aids iron absorption because it reduces the phytate content of the cereals. So hence, if you ferment your cereals, including the wheat, rice, the iron which is present in them will be absorbed to a greater degree. Some fruits which inhibit the absorption of iron, although they are rich in ascorbic acid because of the high phenol content, like strawberry, banana, and melons. When we talk of the requirement of iron and the erythropoiesis, there is an entity called iron restricted erythropoiesis, under which we have four subheadings, which is one is the absolute iron deficiency, then you have the functional iron deficiency, iron sequestration, and impaired iron transport. In the first one, the hepcidin is low, and the rest of the three, the hepcidin levels are increased. So for all practical purposes, I'm going to discuss the absolute iron deficiency, which is basically of interest in clinical practice. Uh, Absolute iron deficiency reflects basically, as the name suggests, it is obvious that is deficiency of iron in an absolute degree. Here, the iron regulatory and erythropoietic mechanisms remain functional and normal. Hepcidin is suppressed because it allows increased absorption of iron from the duodenum and increased release of iron from macrophages and from hepatocytes. The diagnosis of iron deficiency in absolute iron deficiency is simple because there's low serum iron, high TIBC, the transferrin saturation is low, and the ferritin levels are low. When a patient of iron deficiency comes to us, it's very important to find out what is the cause of iron deficiency in this patient. The most common cause of iron deficiency is blood loss. Now, when we are talking of females in the reproductive age group, premenstrual females, the most important cause is the menstrual blood loss. While in males and postmenopausal females, the gastrointestinal tract is the most important cause of iron deficiency anemia. The urinary blood loss and the blood in the sputum are rare causes of iron deficiency anemia. However, patients may have repeated hemoptysis or hematuria, which can cause iron deficiency. Then frequent blood donors can also develop iron deficiency because about 220 milligram of iron is lost with each blood donation. An other cause of absolute iron deficiency is the increased iron requirement or utilization, as occurs in pregnancy or lactation, infant, preschool children, the growth spurts basically. Growth spurts, there is an increased iron requirement. So infancy, preschool children and adolescents, there you can develop, you can have iron deficiency manifestations can occur. Then polycythemia vera, because there is a high rate of synthesis of RBCs. That is why patients can develop iron deficiency. Just a moment. Another cause of absolute iron deficiency is malabsorption, especially when you talk of clinical practice. Celiac disease is an entity which really needs to be ruled out because of a lot of modification and bioengineering. The wheat variety is a hexavalent wheat variety, which is more immunogenic, and the incidence of celiac disease is increasing. So celiac disease definitely needs to be ruled out. Now, patients who have had a gastrectomy or bariatric surgery, they can also develop iron deficiency, which needs to be looked into if such a patient comes to you. Then patients on long-term proton pump inhibitors and H2 blockers, because of a decrease in acidic environment of the stomach, can also develop iron deficiency, as do patients with chronic atrophic gastritis. Then dietary inadequacy of iron is almost never the sole cause. Generally, in such a patient, other causes do exist along with the dietary inadequacy. And in fact, when you talk of dietary inadequacy, the patient will not have only a microcytic hypochromic anemia. It'll be a dimorphic anemia where you will, in addition to have iron deficiency, also have a folate deficiency or a B12 deficiency. When you talk of dietary inadequacy, it will not only be iron deficiency anemia. And you can have combination of multiple factors which can cause iron deficiency. Now, what are the symptoms of iron deficiency anemia? So first of all, the patients will have symptoms which are common to all anemias. So the patient can have fatigue, dizziness, headache, palpitations, dyspnea, lethargy. There can be disturbances in menstruation. And in case of infants, it will be impaired growth. So these are symptoms which are common to all anemias. Then you have symptoms which are specific to iron deficiency. One of these is irritability. These are especially seen in children. Irritability, poor attention span, lack of interest in surroundings, poor work performance and behavioral disturbances, defective structure and function of epithelial tissues, especially affecting the hair, which is why the hair fall, whenever patients come with hair fall, it is very important to rule out iron deficiency in such subjects. Then the skin, the changes can occur in skin. You can have dry skin, the nails. You can see the changes of platinikia, that is flat nails, and koilonychia, which are the curved spoon-shaped nails. Those changes can occur, and these are very specific to iron deficiency anemia. The tongue, where there's glossitis, the mouth, the hypopharynx, and the stomach. In children, especially with iron deficiency, there are increased frequency of infections, which needs to be looked into for controlling the infections. Now, what is pica? Now, pica is the habitual ingestion of unusual non-food substances. So the patient may take earth, clay, laundry starch, or ice. Now, this is very specific to iron deficiency anemia. So if a patient gives you history of pica, sure shot the patient has iron deficiency, and it is relieved very gratifyingly, very fast. Whenever you start giving iron, pica magically disappears. This is one way of knowing that the patient has iron deficiency. Now, this is the glossitis that you can see in iron deficiency in patients with these manifestations. This is a picture showing koilonychia. Now, this is a barium swallow examination of a patient with Patterson-Kelly or Plummer-Vinson syndrome, that is development of esophageal webs in patients with iron deficiency, which may be mistaken or confused with strictures. And when you do a endoscopy, you will find the esophageal webs that are present. Again, these esophageal webs, which are basically the epithelial changes secondary to iron deficiency, disappear magically as soon as the iron deficiency is corrected. Now, what are the progression of findings when you investigate the patient? First and foremost, there will be decrease in the stainable iron in the bone marrow. However, bone marrow is not a modality investigation of choice when we want to investigate iron deficiency. But for academic purposes, first and the foremost, there will be decrease in the stainable iron in the bone marrow. Next step, there will be a decrease in serum ferritin. So ferritin may be considered as a bank of iron in the body. So when initially, as the body requires more and more iron is taken up from the stores. And the first thing that happens in iron deficiency is not the fall in hemoglobin or the change in the indices. It will be a decrease in serum ferritin. So if a patient comes to you with a normal hemoglobin of, let's say, 12 or 13, and you find the ferritin to be less than 10, that is a feature of iron deficiency. The patient has not developed anemia up to now, but his or her stores are totally empty. So you need to treat the iron deficiency at that instance, even if the hemoglobin is normal. The next finding that you will have is desaturation. With further decrease in the iron in the body, there will be desaturation of transferrin. So you will find less, when you see the transferrin saturation will be less than 15%. Then there will be drop in serum iron. There will be increase in the transferrin iron binding capacity. And then only you will see features in the blood smear in the form of microcytosis, hypochromia, and you'll have mild anisopoikilocytosis. So initially, body compensates by using iron as discriminately as possible, and then anemia finally develops when the body cannot compensate for the degree of iron deficiency. So when you order a complete hemogram, you will, what are you going to look at? The first is hemoglobin, obviously, to define anemia, which as per WHO definition is a hemoglobin less than 13 in males, less than 12 in females, and less than 11 in pregnant females. So if you have hemoglobin less than the cutoffs, then it defines the patient has anemia. The next, you look at the MCV, MCH, and MCHC. So if your MCV is less than normal, that is less than 80 femtoliters, it suggests microcytosis. And MCH less than 27 picograms suggests hypochromia. Red cell distribution width, it measures the variation in the red cell size. That is basically is a reflector of anisocytosis. In iron deficiency, the RDW often rises before the MCV falls. So it serves as an early diagnostic clue to the presence of iron deficiency. This is the normal smear that you find where the hypochromia is less than one. The central pallor is less than 1/3 of the size of the RBCs, while this is the smear which is showing iron deficiency anemia with the presence of microcytes labeled as M, the presence of the hypochromia, which is more than 1/3 the central pallor, that is labeled as H, then the P, the pencil cells, and the teardrop cells labeled as T. These are the classical findings in a patient of iron deficiency anemia. This is another smear which is showing this is more of a dimorphic anemia where you're finding even macrovalocytes as well. So you have a patient who has anemia and you have a patient and has a decreased MCV, decreased MCH, and you're thinking this patient has iron deficiency. Then how do you confirm the findings? You will order iron studies where you will be looking at iron, TIBC, transferrin saturation, and serum ferritin. Now, are all of these important? Yes, they are important because serum ferritin, if you get a low serum ferritin, which is less than 30, it clearly says that the patient has iron deficiency anemia. But ferritin happens to be an acute phase reactant. So if there's any infection, inflammation in the body, ferritin will be elevated. In which case, you will have to look at the transferrin saturation. If the transferrin saturation, though the transferrin saturation by definition is 15 to 50%, but any TSAT which is less than 25% in the setting of microcytic hypochromic anemia, iron deficiency definitely is there, and the patient needs replenishment of iron in the body. So this is another slide which is just showing that there will be in iron deficiency anemia. Classically, you will have decreased serum iron, which is less than the normal range. The TIBC will be increased, the transferrin saturation will be decreased, and the serum ferritin levels will be decreased. Also, the other things that you will find are decreased sideroblasts in the marrow, increased serum transferrin receptors, and increased erythrocyte protoporphyrin, which are more of research tools rather than those in clinical practice. Now, this, as I mentioned earlier, serum ferritin is used as a standard test for the assessment of iron stores. However, it's an acute phase reactant. Ferritin values less than 30 is a sensitive and specific test to identify isolated iron deficiency, but it may be elevated falsely in chronic diseases, malignancy, chronic alcohol intake, obesity, and metabolic syndrome. In which case, you will have to look at the transferrin saturation to make a diagnosis of iron deficiency anemia. Now, the new entities which have come up to diagnose iron deficiency are what are called the reticulocyte indices. They assess the effects of changing iron status and reflect the recent erythropoietic activity of the bone marrow and the iron available to the marrow. They are much more sensitive because they are, when we talk of MCV, MCH, they change over a period of 3 months, while these are change with each erythropoietic activity and presence of reticulocytes. So there are various entities, various Coulter counters and automated counters will give you the values, which can be in the form of hypochromic red cells, the reticulocyte hemoglobin, which is also called CHR or red HE. And these are entities which may not be available with all machines, but if the hospital or the center has a 6-part machine, they'll be able to give the reticulocyte indices, which will also help in diagnosis of iron deficiency anemia. If you look at the bone marrow in case of iron deficiency anemia is highly cellular, and you have mild to moderate erythroid hyperplasia, and the normoblasts are small in size. And this is classical erythropoiesis, which is seen in iron deficiency and is called micronormoblastic. And the stainable iron is absent in the marrow. So if you look at this, this is a 4+. The first slide is showing 4+ iron. Second is 3+, and 2+, and the last is 0. So no iron stain when you do a pearl stain of the marrow. However, bone marrow is not a routine investigation done to diagnose iron deficiency anemia. You can easily diagnose IDA by the iron studies only. So once you've made the diagnosis of iron deficiency, how do you manage the patient? So there are 2 things when you manage iron deficiency anemia, which are very important. First and foremost is you manage the anemia. So you have to correct the deficiency of iron. And second, very important is you have to look for the source of blood loss and try to rule out the cause. So if you have a patient with menorrhagia, correct the menorrhagia. If the patient has hemorrhoids, you have to correct hemorrhoids. And especially in postmenopausal females, and males, it is very, very important to look at the cause of iron deficiency anemia, because you may be looking at a malignancy, or you may be looking at serious bleeding disorder, or a presence of hemorrhoids or telangiectasias. So ulcerative colitis, you have to rule any cause which is there. Unless you treat the underlying cause, the iron deficiency anemia tends to be recurrent. Another very common cause that you see in clinical practice is patients on ecosprin, where they have mild gastritis of the stomach, mild gastritis, which can cause blood loss, which is occult, and cause anemia slowly over a period of time, leading to chronic iron deficiency anemia. So all these causes have to be ruled out. So you should do a stool examination for occult blood, but occult blood tends to be episodic and may not be present all the time. Hence, the recommendation nowadays is that don't go by stool occult blood only. If stool occult blood is present, fine. But if the stool occult blood is not present, still the patient should undergo scopies, especially if it's a postmenopausal female or a male that you're dealing with. So you look for hemorrhoids, you do a proctocolonoscopy, and you do upper GI endoscopy. That when you order upper GI endoscopy, it's very important to include the duodenal biopsy to rule out any malabsorption which can be there. And you should do a celiac disease serology, which is very important. Now, after doing all this and still you have not been able to find out the cause of anemia, iron deficiency anemia, and patient has recurrent history of iron deficiency, you should do a capsule endoscopy to look at the small bowel. Even if that is normal, then you other investigations are the radio labeled RBC scan and CT angiography to look for cause of blood loss and the site of blood loss, so that it can, if it is amenable to treatment, then you can treat that. There are certain patients, even after extensive investigations, we are not able to find the cause of iron deficiency, but they tend to have recurrent iron deficiency. And I have a lot of patients who we are giving repeatedly iron injectable irons every 2 months, every 3 months, because they have been extensively worked up by the gastro people also. They've not been able to find out the cause, but the patient keeps having iron deficiency, in which case we have to replenish it with injectable iron. And even those people don't respond to oral iron, so definitely the losses are more than that can be corrected. Or they have malabsorption, which has not been picked up by the routine investigations. When do you transfuse iron deficiency anemia? Because iron deficiency is such a easily treatable anemia, transfusion is not normally done, and it's only reserved for patients who have got severe symptomatic anemia with cardiovascular instability or a continued excessive blood loss, so that you transfuse so that the patient can be stabilized, while the other options are reviewed and the patient, the drugs tend to act. General principles of treatment of iron deficiency are that you can treat them with oral or parenteral preparation. The oral iron corrects the anemia just as rapidly and completely as parenteral iron in most cases, if the iron absorption from the GIT is normal. Iron is absorbed more completely when the stomach is empty. Thus, it's very important that when you give the patient a prescription for iron, it's important that you should tell them it should not be taken with food. Preferably, it is taken either 1 hour before meals or taken 2 hours after meals to allow for proper absorption. And patients who are taking polytherapy, especially ANC patients who also are taking calcium, it's very important to tell them not to take iron with calcium. And calcium can be taken just after meals, while iron has to be taken 2 hours after meals. It is necessary, important, another very, very important point when you treat iron deficiency anemia, it is important to continue treatment for 3 to 6 months after the anemia is relieved. So as soon as your hemoglobin becomes 12 or more than 12, more than 13, you should not stop iron. You should give it for another 3 to 6 months. You should document that the stores have become normal, preferably by repeating a ferritin and seeing the stores are normal. Patients who tend to have repeated losses, you will find that the hemoglobin tends to get corrected. But if you look at the ferritin continues to be low. So it's very important to continue the iron till the ferritin stores are replenished. And also, if a patient you find that despite giving iron, the ferritin is not getting replenished, that means obviously that the patient is losing from somewhere, and you really need to look into the cause of iron deficiency anemia. Iron absorption occurs at the duodenum and the proximal jejunum. Thus, extended release capsules or enteric coated capsules which get absorbed in the lower part of the GI tract are not very effective. So it's important not to use the extended release capsules. Iron preparation used should be based upon the cost and effectiveness and should have the minimum side effects. The cheapest is ferrous sulfate. Now, important to remember is when you're treating iron deficiency anemia, it is the amount of elemental iron which you're giving to the patient which is important. The usual dose, recommended dose for an adult is about 3 to 5 milligram per kg. So for a 50 kg person, it will become about 150 or to 150 to 200 to 250 milligram of elemental iron. So whatever iron preparation you use, it is important that there are various studies which have been done, and they have found that no evidence it suggests that any preparation of iron is better than the other preparation. So it's just important to remember, don't use an extended release preparation. Other than that, you can use any preparation. Different iron salts provide different amount of elemental iron, so that is very important. So when you are prescribing iron, you should know the amount of elemental iron that that particular tablet or a capsule has, and only then prescribe. So if you use Dexorange just is 30 milligram of elemental iron. So if you're going to treat iron deficiency anemia with Dexorange, it is a really an under treatment. Again, if you look at Livogen, it is just about 50 milligram of elemental iron. So unless you give 4 tablets of Livogen, it's not going to work. So whatever preparation you want to give, it is important to make sure that the elemental iron being provided is of the therapeutic range. This is just a chart which is showing that if you give ferrous sulfate as an elemental iron content of 65 milligrams, so you'll need about 3 to 4 tablets. But if you use ferrous fumarate, where you have a 33 milligram elemental iron, you need to give 6 to 8. So if you get Dexorange, you'll need to give 32 milligram, you'll give 6 to 8 tablets, capsules. Nobody gives that amount of Dexorange. So important to remember that your elemental iron content needs to be seen. 10 to 20% of patients who you give iron will have nausea, constipation, or diarrhea, or epigastric distress, or vomiting, which can be managed by smaller doses of elemental iron. You can decrease. So if you're giving 200 milligram of elemental iron to the person, you can try and decrease and get it to 100 milligram. Then slowly increase in dose from 1 tablet to 3 tablets of ferrous sulfate required per day. You can switch to an elixir form, that is a liquid form, or you can switch the preparation of iron, so ferrous fumarate, gluconate, or ascorbate, whatever. You can try and switching the preparations if patient may tolerate a different preparation of iron. And you can try taking the tablet with meals. It will decrease absorption, but still it can be tried. I particularly like to tell the patients to take the iron at bedtime. That somehow decreases the epigastric distress and the GI side effects. So at bedtime, the patient takes 2 hours after dinner. That I found is very useful clinically to help manage the GI side effects. The initial response to iron therapy takes about 7 to 14 days. You expect a modest reticulocytosis at of about 7 to 10% on day 7. Half correction of anemia occurs to about 3 weeks. So if you're going to correct a iron deficiency, if your patient has started with 6 grams and you have a deficit, let's say, of 6 grams, you expect in about 3 weeks a 3-gram rise will occur, and a full correction occurs in generally about 2 months. So if your patient is not correcting in 2 months, that means either what are the few things that you will look into, that either the patient is either non-compliant, or you giving an underdosing of iron, or if the diagnosis is incorrect. If your diagnosis is correct and the patient is compliant and you've given a correct dose of iron, then definitely half correction of anemia will occur in 3 weeks and full correction will occur in about 2 months. But even with the full correction of hemoglobin, remember to give it at least 6 months of 3 to 6 months of therapy beyond the correction of anemia to replete the iron stores, assuming that there is no further loss of blood. So if your ferritin is not corrected, it is important to continue iron till the ferritin is corrected, or you have treated the cause of blood loss. So as I mentioned, because iron deficiency anemia is such a gratifying anemia and easy anemia to treat, if you're not able to, and sadly, it's the easiest anemia to treat, and still you'll find the major cause of referral to hematology is iron deficiency anemia, which is not getting treated. So basically, somewhere, why I wanted to take this topic also was that somewhere we are doing something wrong with iron deficiency, because easy but still not able to treat. So either your diagnosis is incorrect, or if your diagnosis of iron deficiency is correct, then you have given an inadequate prescription, either in the dose or the form of prescription that you've given. Then non-compliance is a very important cause. Then if the patient has complicating illness, you have anemia of chronic disease, especially patient has arthritis, patient has malignancy, patient has metabolic syndrome, in which cases you have anemia of chronic disease, which is compounding the iron deficiency. The hepcidin levels are very high, in which case oral iron is not going to work because absorption is limited by hepcidin. You will have to give IV iron to such a patient. Then you have difficulty with absorption in the presence of antacids or enteric-coated tablets that you have to look into. Then you have missed a diagnosis of iron malabsorption. You're giving oral tablets and the patient is not improving. That means you missed a diagnosis of either H. pylori or celiac disease. So go back and recheck the diagnosis, look at the cause of iron deficiency. And very importantly, continuing iron loss in excess of the intake. So you're giving oral iron, but the patient continues to lose more than what you're giving. So these are causes of failure of iron therapy, in which case you can try the parenteral iron therapy. So if your diagnosis of iron deficiency is correct, and the patient is not responding to oral iron, then it's one of the indications of using the parenteral iron therapy. If the patient is intolerant to oral iron, if the patient has malabsorption, relatively acute needs. Relatively acute needs means something if the patient see, as I mentioned earlier, the time to response to parenteral iron and oral iron is the same. So what do you mean by relatively acute needs? So sometimes with oral iron, there are so many factors to be looked into: the absorption, the diet. So the patient may not respond as easily to oral iron. If you need, suppose the patient is just going to deliver in about 3 weeks and you want the hemoglobin to rise about 3 grams and you're not sure the patient is absorbing well, you've not been able to work up the patient completely. These are relatively acute needs where you can use parenteral iron therapy. So pregnancy is one of the indications, or the patient needs to go for surgery. Again, a relatively acute need where we will use parenteral iron therapy. If the patient has chronic ongoing blood losses or a patient on chronic hemodialysis, again, where there's an element of chronic disease where hepcidin is high and the patient is not going to absorb iron oral, hence we'll use IV iron preparation. How do you calculate the dose of oral irons? Now, previously we used to follow the Gomori formula where it was 2.4 into the hemoglobin deficit into the body weight in kg and used to add 1000 milligram for stores. Generally comes to about 1500 milligram of injectable iron that we need to give. The newer irons, however, come with a fixed dose recommendations like the iron carboxymaltose and iron isomaltoside. So these were the preparations available initially: the iron dextran, the sodium ferric gluconate. Then we moved to iron sucrose, basically, which carbohydrate moieties. Then we have the newer irons, again, which have the carbohydrate moiety, that's iron carboxymaltose and iron isomaltoside. So modalities of use of iron are that you can use total dose iron. That means one sitting or two sittings, you can complete the entire dose requirements, which is what we do with newer irons, or multiple sittings, which we used to do with previous irons. Like iron sucrose also, we used to have multiple sittings of 100 to 200 milligram are given over many weeks. So iron dextran was the old iron that we use, no longer used today because of the risk of, because of a lot of injection site issues and fatal anaphylactic reactions which have been reported with iron dextran. Hence, we no longer use iron dextran. Then came iron sucrose. Now, iron sucrose is basically a complex of polynuclear iron hydroxide in carbohydrate moiety, that is sucrose for intravenous use. Each ml of iron sucrose contains 20 milligram of elemental iron. It is available as 2.5 ml single-use vials. So each vial has 50 milligram of elemental iron. It can be administered only IV. You can give it by a slow bolus over 5 to 10 minutes, preferably given by an infusion over 10 to 15 minutes. How frequently do you give iron sucrose? You can give it as a slow IV injection over 2 to 5 minutes. How we give, basically the maximum is 600 milligram per week, and in one sitting we give the maximum of 200 milligram. So 200 milligram in one sitting and up to 3 sittings a week, so that makes it about 600 milligram per week. So if you have to the deficit of the patient is about 1500 milligram, in which case it will take about 3 weeks for the patient to be given the entire iron sucrose. Iron sucrose, though the risk of anaphylaxis is much lower when you compare it with iron dextran, it still requires a test dose. Then came the newer irons, ferric carboxymaltose. It is a novel iron complex that consists of ferric hydroxide core, again stabilized by a carbohydrate shell, which is in the form of carboxymaltose. It allows for controlled delivery of iron to target tissues of the reticuloendothelial system and subsequent delivery to the iron binding proteins, that is ferritin and transferrin. There is a minimal risk of release of large amounts of ionic iron. Now, problem with iron dextran was this: the large amounts of ionic iron was released, which was responsible for the anaphylaxis. However, with these iron carboxymaltose and my iron maltoside, the amount of iron, the free ionic iron which is released in the serum is very low. So immunogenicity is very low, and hence the risk of anaphylaxis is much lower. So no test dose is required. It is administered IV, and it is given, the usual protocol that we follow are 2 doses given at a gap of 1 week. where we use a dose of any patient more than 50 kg. We give 750 milligram, 2 doses at a gap of 1 week. So the total dose is 1500 milligram completed in 2 sittings. If the patient is less than 50 kgs, we give 15 milligram per kg of doses. So first dose is also 15 milligram per kg, and we repeat it after 7 days, again the 15 milligram per kg dose. And we generally put it in normal saline 100 ml and give it over 10 to 15 minutes. And we have used a lot of ferric carboxy maltose and not found a single anaphylactic reaction. So it's a easy administration, OPD basis, daycare basis, we have used it. Similarly, another preparation of iron is available, which is iron isomaltoside. It is given as a total dose in single sitting of about 1 gram to 2 grams can be given over a single sitting over 1 hour. And again, here also the risk of anaphylaxis is very low and no test dose is required. So whenever you're looking at iron deficiency, important, this is just an algorithm which is just mentioning what I've told you, that you must look at the causes of iron deficiency anemia. You must do scopies of a postmenopausal female and a male, and especially if a female with menorrhagia is there, you have to correct menorrhagia, and you must treat with oral iron beyond the correction of hemoglobin correction. With IV irons, you have given the total dose, so the ferritin is also replenished. So that is not a problem when you're using IV iron, but when you're using oral iron, it is important to correct beyond 6 months, beyond the correction of hemoglobin, so that ferritin is also replenished. Iron deficiency anemia, the differential diagnosis remains the three only differential diagnoses. One is thalassemia, anemia of chronic disease, and sideroblastic anemias. Thalassemias are easily diagnosed because here the RBC count is higher as compared to iron deficiency anemia, and you can confirm it by doing a hemoglobin HPLC. Anemia of chronic disease depends on the sitting that the patient is having. Sideroblastic anemias, however, much less common. So this is just if you have microcytic hypochromic anemia, you order a plasma ferritin. If your ferritin is less than ferritin, as mentioned, as less than 15, but I would prefer to say if it's less than 30, you make a diagnosis of iron deficiency anemia. However, if your ferritin is high and you're getting a microcytic hypochromic anemia, especially if you have profound microcytosis less than 60, in which case you must order HPLC and rule out the presence of a beta thalassemia trait. And anemia of chronic disease is confirmed by the presence of serum iron, which is low, ferritin, which is high, and transferrin saturation, TIBC also, which is low as against iron deficiency, where the TIBC is high. That will be all. Thank you. And if there are any questions, I would really like to take and answer.
For the informative talk. There is a question about one of the
Just a
doctors.
moment. I cannot hear you very properly. Can you hear me? So volume change. Yeah, can you just now repeat the question?
Yeah, there is a question from one of the doctors that is it necessary to prescribe vitamin C every time we give iron
No,
supplement?
no. Vitamin C is not needed at all. In fact, vitamin C is not recommended when you're giving therapeutic irons, which are in the form of ferrous salts. Vitamin C is not recommended. It's not required also. When you're talking of dietary, when you talk of normal diet that you take, because here the iron can be in ferric and ferrous both, in which case vitamin C is important. But when you're giving therapeutic irons, they're all in ferrous forms. So they're already in ferrous forms. You don't need vitamin C to reduce them from ferric to ferrous forms. So you don't need vitamin C.
Ma'am, any data on the which preparation has better absorption?
Yeah, there are multiple studies which have been done, but every study has come to the conclusion that one, that no preparation is better than the other, and number two, definitely the GI tolerance of a particular patient to different salts may be different. So you can use any preparation, which is not an extended release preparation, but if the patient does not tolerate one preparation of iron, you can definitely try another preparation, and the patient may tolerate that better. per se, the GI tolerance in various studies, all preparations, there have been very conflicting data in whatever studies have been conducted so far.
All right, ma'am. This is a very common scenario which is faced by the us medical officers in the wellness centers, that a patient is prescribed, say, for example, ferrous ascorbate, and
Yeah.
uh, because as we know, the studies have shown equivalency, just that the GI side effects will be different.
Yeah.
So, are we well within, say, justified to change the preparation, say, to iron sulfate or iron gluconate?
See, that's what I'm trying to tell you. The 2, 3 points that I mentioned. One is that you should be sure that you're giving the correct dose of elemental iron. So whatever preparation you are using, if it provides elemental iron of 100 to 200 milligram per day, you are absolutely right. Then again, if the patient is tolerating and you're getting a good increment, patient doesn't have any GI side effects, you are well within your right to use that particular preparation of iron. And if the patient is not tolerating the one you have written, if I've written ferrous ascorbate, the patient is not tolerating, you can try a ferrous fumarate. So if the patient tolerates that, very fine. So there is nothing wrong as long as, so any preparation is okay which is not extended release, and any preparation which provides the right amount of elemental iron is okay. And any preparation which the patient is tolerating, again, that is very important. So this is
Alright.
basically trying to tell you, no, there is not, it is not, ferrous sulfate is very good, it's cheap. But ferrous sulfate, again, a lot of patients have GI side effects with ferrous sulfate. So if you have given ferrous sulfate, which is cheap and 65 milligram elemental iron, you're giving FSTDS. And if the patient is not tolerating FSTDS and having abdominal pain and GI side effects, and patient doesn't take that much dose, then you can try switching to a different preparation where you will provide maybe 100 milligram with a single tablet. So you're justified.
All right. Uh, I'll ask, because there are no questions in the chat box currently. I'll ask a very practical scenario, because uh, pure iron deficiency anemia is a bit, say, multifactorial cause of anemias are more common than iron
Yeah.
deficiency. Yeah. Then how do
Oh,
we?
you'll be quite surprised. Plain, simple iron deficiency anemia is very common and sadly not treated properly also.
Yes, ma'am. So the monitoring parts, that is always there. We can monitor through various tests, retic count, and
Yes.
everything. So, in the practical scenario, if it's a mixed form of anemia, then what are the things to note?
See, first and foremost is whenever you're looking at the diagnosis of anemia, the most initial investigations are very important. So your peripheral smear is very, very important. If you have your indices which suggest iron deficiency and you see a peripheral smear which is also consistent with iron deficiency, very fine, you're dealing with pure and simple iron deficiency. But you may have a patient with a dimorphic picture. So whenever you look at anemia, it is important. The first thing that you should order is a CBC with reticulocyte count with a peripheral smear. So these are basic investigations of an anemia. So CBC will, from automated machine, will tell you what kind of indices there are. So if you are microcytic or you're macrocytic or you have normocytic, normochromic indices, then you should look at the reticulocyte count. If the reticulocyte count is low, that means yes, it's an underproductive anemia. Then you should look at the PS, peripheral smear, if it's showing a dimorphic picture. You're finding macrocytes also, you're finding microcytes also. So in addition to ordering in iron studies, you should also order B12 folate levels. So basically, commonly that you see nutritional anemias that you see in practice, you can have a combination of any kind of deficiency. So it's better to treat. So if you're not getting an adequate response with iron, maybe there was something missed at the outset. you should look into celiac also. You should get a celiac serology.
All right, ma'am. There is another question that any relation to meals of iron preparations and use of PPIs and iron preparations simultaneously.
Preferably avoided. It should not be taken with meals. So it's very important, as I mentioned, either 1 hour before meals or 2 hours after meals. And PPIs decrease the absorption of iron. So unless it is very important to give PPI to a patient, iron deficiency anemia, you should tell them not to take PPIs. And PPIs also cause B12 deficiency. So you have to look if a patient has been chronically taking PPIs, the patient can have a hypoglycemia if your diet is low in iron. Is just manifestation of iron deficiency.